When treating the foot for plantar fasciitis, we have to make sure, obviously, that we have a proper diagnosis for the condition. But what's unique about this condition is that we can have a flat foot, or pes planus, pes cavus, which is a big arch, or anything in between, and still get plantar fasciitis. Plantar fasciitis is irritation of the plantar fascia, but the fascia itself doesn't really have a job. It's not a contractile tissue. It kind of holds things in place. So it's very important to understand the sling muscles and what supports the actual arch of the foot. But in the case that we do have a diagnosis that's proper for plantar fasciitis, we're going to take our ultrasound gel and apply it to the bottom of the foot. We have to realize that the plantar fascia does not have an origin and an insertion point, but rather a proximal and a distal attachment point. It's more like a ligament. When we start, we always begin at what's called the medial calcaneal tubercle, which is the proximal attachment point for the plantar fascia. We will then slowly move up the medial side of the foot to the proximal phalanges, or the proximal toe, where the distal attachment point is. And we will go back and forth. What's unique about the plantar fascia, it's a very large piece of tissue here on the bottom of the foot, but due to mapping, we will definitely be able to localize the area that needs to be treated so that when we actually treat it, we'll know right where to go. Just a little bit of information on plantar fasciitis. The plantar fascia is there's a very common differential diagnosis. We want to make sure if the pain is in the heel area that the patient does not have a calcaneal stress reaction or stress fracture. That would have to be visualized through an MRI to see the bone marrow edema, and X-ray is usually not sensitive enough to pick that up.